So, when you're standing at the scrub sink, just looking at the board for the day.
Yeah, mapping it all out.
Right. And you see a tumor resection on there, it just carries this very specific kind of weight.
Oh, absolutely.
Because we treat the operating theater like this, sanctuary of precision. You find the pathology, you resect it, you get hemostasis, and you close.
Simple as that.
If only. Because the reality is, the tissue we're dealing with, it has its own agenda. It's totally autonomous.
It's rebellious.
Yeah, rebellious is the word. It really doesn't care about anatomical boundaries or your nice, clean surgical planes.
It really doesn't.
Yeah.
Which is why we're here. Welcome to this high-yield revision deep dive. We are speaking directly to you, the surgical resident gearing up for the MRCS exam.
Exactly. We're two fellow surgeons here to drill down on the undeniable facts you need to know about neoplasia.
But before we get into the pathology, if you want to maximize your revision time, you need to head straight to medsynclimited.com/Anki to get the MRCS Accelerator A-Anki deck.
Such a lifesaver.
It really is. It contains over 2,400 questions across 23 themes, and that includes 15 subspecialty topics designed specifically to help you recall commonly tested facts.
Because, active recall is really the only way this sheer volume of information is going to stick.
100%.
So our mission today, we are mapping out the pathophysiology, the classification, and the clinical behavior of neoplasia.
We're keeping it fast, too.
Yep. A rapid-fire question and explanation approach to lock in exactly what the examiners are looking for because before you even pick up a scalpel, you've got to decode that pathology report.
Right. The nomenclature literally dictates your surgical approach.
So let's start there with the behavioral and histogenetic classification. When a pathologist looks at a slide, how are they, fundamentally categorizing all that cellular chaos?
Well, the primary split is behavioral, so benign versus malignant. But the histogenetic classifications is where the real surgical implications start.
Because we're looking for the exact cell of origin.
Exactly. Is it epithelial? Is it mesenchymal, meaning, connective tissue? Or is it lymphoid and hemopoietic?
Right.
And once the pathologist figures out that origin, they grade the tumor based on its differentiation. They're basically measuring the cellular memory of the tissue.
I like that. I've always thought of differentiation as a measure of anarchy, really.
That's a great way to look at it.
Yeah, because a well-differentiated tumor, it still respects its lineage. Like, the cells still look like the parent tissue, they often keep their polarity, and they just generally behave less aggressively.
That's a really solid way to visualize it. Because as it degrades to, say, moderately differentiated, that cellular architecture just starts breaking down.
You start seeing the pleomorphism.
Right, the increasing pleomorphism. So big variations in cell size and shape.
Yeah.
And then by the time it's poorly differentiated, the cells have almost entirely forgotten their identity.
They're just highly aggressive at that point.
Yeah, they only care about replication, not function. And if a tumor completely defies histogenetic classification, like if it's so primitive, you can't even tell if it used to be epithelial or mesenchymal.
Right.
We call that anaplastic.
Right. And the MRCS examiners, they absolutely love testing the naming conventions tied to that histogenetic origin.
Oh, they do?
The general rule for you guys listening is that the suffix, oma, implies a benign lesion, but the prefix tells you the tissue.
Exactly. So for benign epithelial lesions, we see papillomas if they come from squamous epithelium.
And adenomas if they arise from glandular epithelium.
Right. But when those epithelial cells turn malignant, that suffix shifts to carcinoma. So squamous cell carcinoma or adenocarcinoma.
And connective tissue basically follows that same logic, right?
Pretty much. A benign fat tumor is a lipoma, bone is an osteoma, but a malignant mesenchymal tumor that is always a sarcoma.
Got it. Now, we also have to account for those embryological outliers that always seem to pop up in OSCE stations. I'm talking about teratomas and blastomas.
Yeah, you have to know those.
Teratomas are such a fascinating surgical challenge because they involve all three germ cell layers, right? Ectoderm, mesoderm, and endoderm.
It's wild. You can open a mass and find hair, teeth, thyroid tissue.
It's crazy. And the clinical pearl here for the exam is that ovarian teratomas are overwhelmingly benign and cystic, while testicular teratomas tend to be malignant and solid.
That's a huge point to remember.
But what about blastomas?
So blastomas are embryonal tumors.
Yeah.
They happen when developmental cells just fail to mature, and they arrest in this primitive, highly proliferative state.
Right.
So under the microscope, something like a nephroblastoma Wilms tumor it looks incredibly similar to an actual embryonic kidney.
Wow. Okay, let's unpack this for a second and challenge that OMA rule, because examiners aren't going to just test you on a lipoma. They want to test the
They
traps.
don't want to catch you out.
Exactly. So if OMA means benign, why do hepatoma, melanoma, and lymphoma exist? I mean, they sound benign based on the rule, but clinically they are incredibly lethal.
The classic misnomers.
Right.
Yeah, these are basically historical artifacts. Pathologists coined those terms decades before any strict international nomenclature rules were actually standardized.
So they just got grandfathered in.
Exactly. A hepatoma is actually a hepatocellular carcinoma, a melanoma is a melanocarcinoma, and a lymphoma is a lymphosarcoma.
So you really have to actively override your brain's prefix-suffix logic when you see those three words on an exam paper.
You do, because they are always malignant.
Okay, so now that we've mapped the nomenclature, we need to look at the actual mechanism of action. Like, how does a healthy cell cross that threshold into malignancy?
Well, the multi-step theory of carcinogenesis dictates that it's never just a single event. It starts with latency.
Right, there's this massive temporal gap between the initial genetic hit and a clinically detectable mass.
Yeah, just think about the mathematics of tumor doubling times. A tumor needs to reach about 1 billion cells to be a 1 centimeter clinically palpable mass.
Which is huge.
It's massive. That requires roughly 30 population doublings. So the first few mutations, they don't instantly grant the cell the ability to outcompete normal tissue.
So the very first step is initiation.
Right. The cell's exposed to some carcinogen radiation, a virus, a chemical, which induces this irreversible structural change in the DNA.
The cell now has neoplastic potential, but it might just sit dormant for years.
Exactly, because initiation on its own isn't enough to drive growth. It requires promotion.
Okay, so a promoter is an event or an agent that forces that specific initiated cell to undergo clonal proliferation.
Correct. The promoter itself doesn't actually cause DNA damage. It just forces the already damaged cell to multiply.
Got it.
And as that clone expands, it accumulates more and more spontaneous mutations until it reaches the final stage, which is persistence.
Right, and this is where the biological brakes just completely fail. Initiators and promoters aren't even necessary anymore. The tumor is fully autonomous.
It's running the show.
It really is. It secretes its own growth factors, it forces angiogenesis to secure its own blood supply, and it develops invasiveness.
Yeah.
But this total rewiring of the cell requires a fundamental breakdown in two major categories of genes, right? Oncogenes and tumor suppressor genes.
Yeah. To understand the mechanism here, just consider the fail-safes in an intensive care unit. A proto-oncogene is like the ventilator's standard drive mechanism. It carefully regulates normal cell growth.
Okay.
But when it mutates into an oncogene, it's as if the ventilator's pressure gauge just gets jammed on maximum.
Oh, wow. So think of an oncogene as a jammed accelerator pedal in a car.
Exactly. It becomes this dominant stimulatory gene, aggressively forcing the cell into constant division. You only need one of the two alleles to mutate for an oncogene to wreak havoc.
So the oncogene is actively driving the chaos.
Okay.
But a healthy cell has repair mechanisms to stop that, which is where tumor suppressor genes come in.
Right.
Because they're recessive inhibitory genes, so you have to lose both copies for the system to fail. So think of a mutated tumor suppressor gene as a cut brake line.
That's a perfect analogy.
But I want to drill down on the functional difference within these suppressors. Specifically, what is the difference between caretaker and gatekeeper tumor suppressor genes?
Let's stick with the hospital analogy. Caretaker genes are your maintenance engineers. They are constantly moving through the genome, finding minor DNA mismatches, and physically repairing them.
So they maintain genomic stability.
Exactly. Now, gatekeeper genes, those are the ICU attending physicians, they monitor the overall health of the cell. If they detect DNA damage that the caretakers haven't fixed, they step in and arrest the cell cycle at the G1S checkpoint.
Just to buy time for repairs.
Right. But if the damage is catastrophic and irreparable, the gatekeeper initiates apoptosis. It literally sacrifices the individual cell to protect the entire organism.
And the ultimate gatekeeper that every single surgical resident must intimately understand is the P53 gene.
Without a doubt, P53 is located on chromosome 17p, and its mutation is the single most common genetic abnormality in human cancer.
Which makes sense.
Yeah, because when P53 is inactivated, the cell loses its ability to pause the cell cycle, and it loses its ability to trigger apoptosis.
So it just divides with shattered, mutated DNA, passing those profound errors to the next generation.
Exactly. And a clinical manifestation of a germline P53 mutation is Li-Fraumeni syndrome. That's where patients develop sarcomas, breast cancers, and brain tumors at alarmingly young ages.
It's devastating. Now, the other heavy hitter in MRCS genetics is the RB1 gene and the two-hit hypothesis.
Right, so the RD1 gene regulates that exact same G1S checkpoint. But because it's a tumor suppressor, it's recessive. The two-hit hypothesis explains why familial retinoblastoma presents so differently from sporadic cases.
Because if you inherit one defective RB1 allele, every single cell in your body already has that first hit.
Exactly. You only need one single spontaneous mutation in the retinal cell, the second hit, to initiate the tumor. And that's why familial cases are often bilateral and occur in infancy.
Whereas a patient with two healthy alleles requires two incredibly rare spontaneous genetic errors to occur in the exact same retinal cell.
Which is highly unlikely.
Right, which makes sporadic retinoblastoma rare, unilateral, and much later in onset. It's just a perfect mathematical model of carcinogenesis.
It really is.
But let's bring this back to the surgical field. Because a tumor just growing in isolation isn't usually what makes a case inoperable. It's the invasion. The transition from benign expansion to malignant infiltration that fundamentally alters our surgical planes.
It changes everything. Benign tumors expand cohesively. They're usually encapsulated by this rim of compressed fibrous tissue. So when you palpate them, they're mobile. They just push normal structures out of the way.
But malignant tumors don't respect those boundaries.
Not at all. They are fungating and infiltrating. They lack a capsule and physically anchor themselves right into the surrounding stroma.
And the mechanism behind that infiltration is what fascinates me, because it's an active biochemical invasion. For a cell to break away from the primary tumor, it literally has to downregulate its cellular adhesion.
We call that epithelial-mesenchymal transition. Normal epithelial cells are tightly bound together by surface adhesion molecules, primarily E-cadherin. It acts like molecular Velcro.
So malignant cells downregulate that E-cadherin expression, which allows individual cells to just detach from the primary mass.
Exactly. And once they detach, they upregulate their motility.
But to actually move anywhere, they have to physically clear a path through the dense extracellular matrix and the basement membrane. I mean, they can't just squeeze through.
No, they literally digest their way out.
Wow.
Yeah, they secrete matrix metalloproteinases, specifically type 5e collagenases. These enzymes cleave the collagen in the basement membrane, creating these microscopic tunnels for the tumor cells to crawl through.
They just dissolve the host's structural integrity.
Basically, yeah.
Here's where it gets really interesting, because that microscopic reality creates massive clinical traps for us as surgeons. Let's look at the classic OSCE scenario, the cleomorphic adenoma of the parotid gland.
Oh, this is a classic trap.
Right. On imaging, and even under your fingers in the OR, it feels perfectly encapsulated. It's a benign neoplasm. So if the examiner asks if you can just perform an enucleation, simply shelling out the tumor along that capsular plane, why is that an automatic fail?
Because that capsule is a macroscopic illusion. It's a false capsule.
Right.
It's not a true fibrous barrier created by the tumor to contain itself. It's just compressed, normal parotid tissue.
So it's leaky.
Highly leaky. Histologically, there are tiny microscopic fingers of the adenoma that protrude directly through and into that compressed tissue.
So if you just shell out the central mass, you leave hundreds of those microscopic tumor fingers behind in the surgical bed.
And recurrence is guaranteed. You must perform a superficial parotidectomy to take a healthy margin of normal tissue.
That is the difference between knowing the definition of a tumor and knowing its actual behavior. Now, once those malignant cells breach the basement membrane and enter the vessels, they metastasize.
Yes.
And they have very specific preferred routes based on their histogenetic classification, right?
They do. Carcinomas, which originate from epithelial tissue, strongly favor the lymphatic system. They embolize through lymphatic channels straight to regional lymph nodes.
While sarcomas arising from connective tissue typically bypass the lymphatics entirely.
Right. They invade directly into the venous system, spreading hematogenously to the lungs or liver. And then we also have transcoelomic spread.
Transcoelomic. That's when a tumor breaches the serrata of an organ and just sheds cells directly into a body cavity.
Exactly.
The classic example being a Krukenberg tumor, where a gastric adenocarcinoma drops cells through the peritoneal fluid to seed bilaterally on the ovaries.
Which is terrifying.
It is. But we also have to recognize that hematogenous spread isn't random. The seed and soil hypothesis tells us certain cancers have an affinity for specific microenvironments. Bone is the classic example here.
Definitely. If a patient presents in the ED with a pathological fracture like a femur snapping from minimal trauma, you should immediately suspect metastasis from one of 5 primary carcinomas: breast, bronchus, thyroid, kidney, or prostate.
Because those cells have specific surface receptors that bind perfectly to the bone marrow stroma.
Exactly.
Now, this metastatic spread explains the physical symptoms we see, right? Like obstruction, mass effect, bleeding. But the tumor's impact is rarely just structural.
No, not at all.
Because as these cells regress to a more primitive state, their gene expression goes completely haywire, which triggers systemic biochemical chaos. Which brings us to perineoplastic syndromes.
These are the remote effects. The tumor cells start transcribing genes they have absolutely no business transcribing, leading to ectopic hormone production.
Give us an example.
Well, a small cell carcinoma of the lung is fundamentally a neuroendocrine tumor, so it can inappropriately synthesize and secrete adrenocorticotropic hormone, ACTH,
Flooding the body with cortisol.
right, causing a rapid onset Cushing syndrome. Or it can secrete ADH, leading to severe hyponatremia through the syndrome of inappropriate antidiuretic hormone.
And we also frequently see squamous cell carcinomas of the lung secreting parathyroid hormone-related peptide, PTHrP.
Yes, that's a big one.
Because it binds to PTH receptors in the bone and kidneys, causing this profound, life-threatening hypercalcemia that presents long before the actual lung mass compromises respiration.
It's wild how systemic it gets.
It really is. But this endocrine relationship is sometimes a two-way street, because certain tumors don't just secrete hormones, they actually require them to survive.
And this tumor dependency provides a critical non-surgical avenue for treatment. It's a vulnerability we actively exploit.
Right.
Like, a significant percentage of breast carcinomas retain the estrogen receptors of their parent tissue, so their proliferation is heavily dependent on estrogen binding.
So if a biopsy confirms the tumor is ER positive, we can utilize selective estrogen receptor modulators like tamoxifen.
Exactly. Tamoxifen competitively binds to those receptors, blocking the endogenous estrogen and basically starving the tumor of its growth signal.
And we see the exact same physiological vulnerability in prostate cancer, which relies on androgenic stimulation. If we remove the testosterone, the prostatic carcinoma cells undergo apoptosis. We can achieve this surgically via bilateral orchidectomy or medically using LHRH agonists.
The mechanism there is brilliant.
It is. You flood the pituitary with luteinizing hormone-releasing hormone. Initially, you get this flare of testosterone, but within days, the pituitary receptors downregulate and desensitize, profoundly crashing testosterone production to castrate levels.
It's highly effective initially. The danger, though, is that tumors are genetically unstable. Over time, clonal evolution occurs.
So they find a way around it.
Right. The cells acquire new mutations that allow them to bypass the hormone receptor pathways entirely. They become hormone refractory, which is why these blockades are rarely curative in the long term.
Yeah, that makes sense. Now, when a tumor changes its behavior like that, we need a way to track it systemically. That's the role of tumor markers, proteins shed into the blood by the neoplasm, like PSA for prostate cancer or CEA for colorectal cancer.
Yeah.
But are these markers reliable enough to replace a biopsy for initial diagnosis, or are they strictly for post-op monitoring? There's a trap here for residents.
There's a huge trap. The trap is thinking tumor markers are diagnostic. They absolutely aren't.
Right.
They lack the specificity required to replace a tissue biopsy. Benign inflammatory conditions can elevate them, and some really aggressive tumors produce none at all. You just can't diagnose cancer purely on a blood draw.
So their true clinical utility lies in their kinetics during post-operative monitoring.
Exactly.
Right. So if you perform an anterior resection for a colorectal tumor and the patient's CEA level plummets to baseline, you have biochemical confirmation of source control.
Beautiful feeling.
It really is.
Yeah.
But if during a follow-up clinic 6 months later that CEA level begins to exponentially rise, it acts as an early warning system.
It tells you there's microscopic recurrence or maybe a liver metastasis long before a CT scan can detect a macroscopic lesion.
Okay, so we've covered the cellular origins, the genetic drivers, the invasion, and the systemic effects. But the final piece of the MRCS puzzle is staging.
Bringing it all together.
Yeah, how do we synthesize all this pathology to determine the actual surgical plan and the patient's prognosis? For colorectal cancer, the gold standard is the Duke's classification.
Right.
It's a pathological staging system based entirely on the resected specimen. But why do the specific boundaries in Duke's matter so much biologically?
It all comes down to lymphatic access. Dukes A means the tumor has invaded into the bowel wall, but not through the muscularis propria, so the risk of metastasis is low.
Okay.
Dukes B means the tumor has breached the muscularis propria and invaded into the subserosa or pericolic fat.
So it's broken through.
Yes, and by breaking through that muscular barrier, the tumor gains access to a much richer network of lymphatic and vascular channels, which significantly worsens the prognosis.
Got it.
Dukes C indicates the tumor has successfully colonized the regional lymph nodes, and Dukes D indicates distant metastasis.
Makes perfect sense. Now, for nearly everything else, we rely on the TNM system, right?
Right.
Like breast cancer. T describes the local extent of the primary tumor, N quantifies the regional lymph node involvement, and M confirms the presence or absence of distant metastasis.
Exactly.
But the staging system that dictates immediate surgical action in the operating room is for malignant melanoma, and that relies entirely on depth.
Yes. Historically, there was Clark's level, which staged melanoma based on anatomical layers, so level 1 in the epidermis, level 5 in the subcutaneous fat. But it really lacked prognostic precision.
Right, so today, we exclusively use Breslow's thickness.
Yes. This is an objective mathematical measurement in millimeters under the microscope. The pathologist measures from the granular layer of the epidermis, the stratum granulosum, straight down to the deepest infiltrating malignant cell.
And the reason depth matters mathematically is because the deeper the tumor penetrates the dermis, the higher the probability it intersects with dermal lymphatics and capillaries.
Exactly. A Breslow thickness of less than 0.76 millimeters has a highly favorable prognosis. But once it crosses 4 millimeters, the risk of systemic escape is massive.
So what does this all mean for the scalpel? For the MRCS, you must know how Breslow's thickness alters your surgical margins in the UK.
It is a very strict protocol. If the Breslow thickness is 1 millimeter or less, the surgeon must excise a 1 centimeter margin of healthy skin around the lesion.
Okay.
If the thickness is between 1.01 and 4 millimeters, that margin expands to 2 centimeters. And if it's greater than 4 millimeters, you take a 3 centimeter margin.
Wow, so you cannot safely close that defect primarily at that point.
No, you are moving into skin grafts or local flap territory based purely on a microscopic measurement.
It's the ultimate example of pathology dictating surgical technique. Well, we've mapped out the essential terrain today. But before you get back to your flashcards, I want to leave you with a clinical reality to consider.
Always good to have some perspective.
Yeah. We discussed germline mutations earlier, like the APC mutation in familial adenomatous polyposis, where a patient has a near 100% certainty of developing colorectal cancer by their 40s, or Liefers-Menis syndrome.
Yeah.
As a future attending surgeon, you will be the one sitting across from a healthy, totally asymptomatic 20-something-year-old recommending a prophylactic total proctocolectomy.
Favy.
It really is. Think about the profound psychological weight of removing an entire organ system from someone who isn't even sick yet, simply because their genetics dictate an inevitable malignancy. How do you approach that conversation?
Yeah, balancing the hard science of genetic certainty with the profound impact on a patient's quality of life that is the true art of surgery.
Absolutely.
Listen, if this deep dive helped clarify your revision, make sure to hit follow on the show so you don't miss our upcoming pathophysiology breakdowns. And take a second to rate it if you learned something today.
And as you move closer to the OSCEs, remember that theory just isn't enough. Head back to medsynclimited.com to pick up their surgical simulation kit.
It's essential.
It really is. It comes with a high-fidelity suturing kit, microsurgery instruments, and just the tactile practice you need to build that muscle memory before you step into the exam hall.
We want to hear your perspective on today's material, too. What specific pathological mechanism always trips you up? Drop a comment or a question for us.
Keep drilling the facts, respect the pathology, and we'll see you on the next deep dive.